We have one fantastic speaker and we have me, so I'll do my best. I don't know if it's possible to get the lights down a little, just for looking at the ECGs. Afternoon, everyone. Thank you very much to Shovik. Thanks to the organisers for asking me to come along. Great privilege. So, ECGs, it says cases and traces. Now, traces in my world normally means intracardiac electrograms, and I guess if we started showing those, there'd be a mass exodus out of the door. I'm guessing there aren't many, if any, electrophysiologists in the audience, so there might be the odd little trace in here, but nothing to be concerned about. I think it's worth relaying that this is generally how ECGs are taught in England or the UK. I suspect it's a bit more sophisticated at the Mayo, but that's generally what we do over here. ECGs don't tend to feature very strongly in medical school teaching or junior doctor teaching, which I think is a shame. It's a bit of a learn on the job if you get the chance, if you happen to be with someone who's interested in ECGs. And as we all know, you can learn a lot from an ECG. Okay, so I will speak for about 45 minutes. I've got a few questions and then I'll hand over to Dr. Arisvathan and we'll see how we go with some interactive voting. So please vote. The guys at the back know who's not voted and there'll be a spotlight shone on you if you haven't voted. That's what they've told me. So have a good look at this one, because when we go to the questions, we'll have to flick off the ECG. So please have a good look at these. So there's nothing really esoteric. These are cases I've come across, some of them recent, some of them a couple of years old, all genuine bona fide cases which highlight some important issues, I think, where the ECG is, if you like, the starting point. So that's our 12-lead ECG. So please, everyone, have a good look at that, and we'll have a vote. So, 4 options. What does the ECG show? Atrial flutter, atrial tachycardia, sinus rhythm, sinus tachycardia. Unfortunately, I can't flick back to the ECG. I think it completely wrecks the voting. So, see how you go. Poll open. How many have we got? We've got a decent number, haven't we? Yeah, okay, good. So let's have a look how we did. So, sinus rhythm. So that's what I was expecting most people to say. Some of these ECGs have got more than one correct answer, and someone who taught me ECGs years ago said you can always dig yourself out of a hole. If someone argues with you about an ECG, you can always say there's always 2 or 3 correct answers for the same ECG. So, okay, most people thought sinus rhythm and a bit of a spread. No one thought flutter. Right, okay, well, let's go back and have a look at it. So that was the ECG. This was the referral letter I got, which said, so I thought it was worth highlighting interventional colleague. Slightly higher than orthopaedic surgeon on the evolution of ECG interpretation. Okay, so could you kindly give your opinion? And this is something that I got also when I was a junior colleague, which was some of my other colleagues would say, you don't need to see the patient. We've seen them, we've done the ECG, we've done the test, you don't need to see them, just admit them for pacemaker, just get them in for ablation. And I've always resisted that because I think it's very important to meet the patient, take a history yourself, and work out what you think the right thing to do is. So as you can see in this text, this young girl admitted for some surgery. Her ECGs show quite plainly sinus tachycardia, rates of 170. Her mother says she's had this a long time, and recently she had sinus tachycardia. Now, I would immediately be concerned about such rapid rates as being put down to sinus tachycardia. I suppose it's not impossible, but I think it's quite unusual. If your ECG is at rest and you're banging along at that rate, I think you really want to be thinking about a few other things. When I met her, she said she'd always had a rapid heart rate. She was told it was normal for her. And she'd seen a lot of doctors over the years over this, GPs, general physicians, general cardiologists, who'd all said, it's just you've got this heart rhythm, rapid sinus tachycardia, don't worry about it. So that was her Holter. So that demonstrated that she was tachycardic a lot of the time. So you can see it does slow a bit when she's asleep. If you see a completely flat line on a Holter, you've got to worry about that, haven't you? Often it's because a patient may have a pacemaker in. But here we've got a variation, but you can see it's still very rapid during the day and still 120 beats when she's asleep at night. So let's have a look at this ECG in a bit more detail. So for the eagle-eyed, those P waves are not normal. They're inverted in lead 1 and lead AVL. So sinus rhythm wouldn't normally look like that. Your P wave should be upright in lead 1. Lead AVL, I think it can be upright or it can be positive, negative. Sometimes the positive is so small in AVL, it does look a little bit negative, but lead 1 particularly, you should have a positive P wave. If you have a negative P wave in lead 1, when I'm teaching ECGs, I will say the first thought should be, has the ECG been wired up correctly? If there's been left and right arm reversal, then you'll get a negative P wave in lead 1. But you'd also get an upside down QRS as well, whereas you can see here the QRS looks normal, it's upright, but the P wave is upside down. So this isn't normal, this isn't sinus rhythm. For those that want to look at things in more detail, I always worry when we talk about P-wave morphology that people are going to say you need to get out a bit more, but you can spend a long time looking at P-waves and trying to work out where the arrhythmia is coming from if you think it's an atrial tachycardia. There's lots of different algorithms out there. This is one that I happened to be involved in years ago, so I use it, I like it. It starts off with lead V1, looking at the P-wave. It's not by any means foolproof. In fact, this bit here lets it down a little bit. But it's a good starting point. It was a little bit about when Dr. Alice Vathan was talking earlier about QRS morphology and working out, looking at lead V1, is it with the VT, is it a negative or a positive QRS? It's the same here. If you've got a very upright, positive P wave in lead V1 with no negative component to it, that's very likely to be a left atrial focus. Whereas if you've got the reverse and a deeply negative P wave in lead V1 with no positive component, that's likely to be a focus very near to the chest wall, sort of right atrial free wall, tricuspid annula, something like that. So atrial tachycardia, just a couple of quick words on that. Yes, they can come from anywhere in the right or left atria, but they do tend to cluster a little bit. And these are the spots. So when we're doing ablation, you sort of have this figure in your mind or something like it. You know the areas that atrial tachycardia can come from. You hopefully know what the P-wave morphology looks like, and then you combine that with your intracardiac mapping, and hopefully it all makes sense. So these are the sort of clusters of where you'll see them around the pulmonary veins, ostium of the coronary sinus, AV node, crista terminalis, on the tricuspid or mitral annuli. So they can cluster in various places. So this is a sort of throwaway for the intracardiacs. But so we put some catheters into this young girl to just see what was going on. I think she was about 21, 22 when we did the procedure. And again, we won't need to go into detail. Catheters in the heart, you display intracardiac electrograms. And when she's in her normal rhythm for her, which is her atrial arrhythmia, the earliest signal is right out here on the coronary sinus, distal coronary sinus. So that doesn't necessarily mean that's where it's coming from, but the earliest signal in the heart where we had our catheters, so this is wrapped around the right atrium, and this is in the coronary sinus around the left atrium. So if this was a sinus rhythm, which we're pretty confident it isn't, because we've been talking about the P wave, you'd expect to see the earliest signal maybe somewhere appearing on this catheter, which is down here, these intracardiacs here, and yet the earliest signal in the heart is from this catheter. So this was coming from the left atrium, which would fit with what we said about what the P wave looked like. And then I thought it was worth, I put this in because I think for people who want to do EP, it's worth knowing that you can do things in the EP lab, which are very interesting, very exciting, to work out mechanism of tachycardia. So we went through that, we worked out this was an atrial tachycardia. And then I think it's worth just showing that, unfortunately, catheter ablation, there's a reality to it which doesn't always make it easy. And what I mean by that is, so ideally you'd like to move the catheters to the heart, find the focus of the atrial tachycardia, beautifully identify it and burn it away, and it's all sorted out. But in this particular case, as we sometimes have with these, every time the catheter brushed over the area where the tachycardia was coming from, it would just stop it. And we'd all have to wait 10 or 15 minutes and it started again, and then we do some more mapping, and just when we think we're getting close, tachycardia stops, and this can then go on and be quite a prolonged, protracted procedure. And in the end, we ended up with what I sort of referred to as, so this tachycardia was coming from the left atrial appendage, the base of the left atrial appendage, and it would be nice if I could show you a slide that just had one or two little red dots where we identified very accurately where it's coming from. But because of what was going on, we ended up doing a wider area of ablation around here because we wanted to make sure we try and get this as accurately as possible, which we did. But as I said, it wasn't as straightforward as you would wish. But that was her back in normal rhythm, and that's her nice upright P wave in V1. So we've got another slide in a moment, but the issue of identifying who's in sinus rhythm and who's not in sinus rhythm is sometimes not as straightforward as people may wish it to be. So, case 2. Have a look at this. So we've got a few spikes on there. So this was from someone who was admitted a few weeks ago, actually. Okay, so there's a fair bit going on, I would say. Pacing and pacing ECGs. So, here we go. There are your options. One of them was pleading for a cardiac physiologist to come along with a programmer and try and help you work out what on earth was going on, which is usually what most people do. Is there a problem with the atrial lead? Is there a problem with the ventricular lead? Is this completely normal pacing function? Don't need to worry. Or something called ventricular safety pacing, which you may have heard of now and again. You do see it, actually, that phenomenon. So how are we doing? Nearly there, decent number, few more. Quick before the spotlight lands on you, and then you have to stand up and give your answer. Okay, so let's have a look what people thought. Right, so half the people thought there was an issue. I mean, again, I wouldn't blame anybody for thinking these things. Some people thought it was a normal pacemaker. Others said, please just get the cardiac physiologist. My brain's aching trying to work this out. Atrial lead problem. So we've got a bit of a spread, haven't we? Most people thinking there's a ventricular lead problem. Well, there's a second part here. Where is the ventricular lead positioned? Now, we can't flick back to the ECG. I don't know if people can still remember what it looked like, if you want to have a go at that. Where do you think the ventricular lead was positioned, looking at that ECG? Do you need an X-ray before you can answer that? Or right atrium, apex right ventricle, or interventricular septum, which, as you know, is where often right ventricular leads are positioned these days. Okay, shall we have a look? Apical, one out. Septum. I need a chest X-ray, a quarter of the people thought. So I guess there's some people who thought, I'm just getting a cardiac physiologist and I'm ordering a chest X-ray. So that's fine. Nothing wrong with that. The interventionalist. That's right. That was the letter from the GP when the patient came up who said, patient's got pacemaker in, it doesn't look like it's working properly. So let's have a look at it. Now, you know, you could spend a long time looking at this. And again, I think there's probably a few different explanations, but what about where this lead is positioned? Well, what I tried to look at was there a recurring theme through the ECG? Are there some beats which are the same? Because there's a lot going on. So if you identify that beat there on the left, and you can see that is a recurring theme. So that seems to be the predominant paced beat going on. And there's two spikes, And for argument's sake, I think it's fair to say one's probably atrial spike, one's probably ventricular spike. You often don't see a P wave after an atrial spike. It's difficult to see on a 12-lead ECG. Sometimes you see a little bump, sometimes you don't. Anyway, so that looks like a recurring theme. That is classical right ventricular apical pacing. Yeah. So if you get very little or no R wave across the precordium, it's like a funny left bundle branch block, isn't it? And then here in the inferior leads, there's a sort of QS here in the inferior leads. That's classical right ventricular apical pacing, which is what we had here. So I think we could say that. What do other positions look like? Well, that's septal. Sorry, it's a bit blurred. Septal pacing, where a lot of leads are put these days. It's handy to know these things, I think, have a vague idea of what the ECG is meant to look like. QRS is, you see an R wave appearing here, which we didn't see with the apical pacing, and look at the inferior leads. They've got a big R wave on them. So septal pacing looks different to apical pacing. And then this is obviously someone who's heading for biventricular pacing or cardiac resynchronization therapy. They've got broad left bundle branch block beforehand, and then afterwards, obviously this is a nice example, they don't always look like this, they've got a nice QRS, narrow QRS afterwards. And then His bundle pacing, which is making a bit of a comeback. People may have heard of that or come across ECGs. So here you can see the QRS looks relatively narrow. It's borderline, isn't it? There's a little delay between the pacing spike, a couple of small squares, and the QRS. So this is where the pacing lead has been screwed into the bundle of His to create a narrow, capture the ventricle, but with a narrow QRS rather than a broad, desynchronous one. Okay. So back to what on earth we were looking at here. So if we look at our pacing spikes and map out A to A and V to V, which we could all do, and then I just sort of map these through. So these aren't pacemaker timing cycles. This is just looking at the intervals on the ECG. So the blue lines represent the timing between each atrial spike, the red, the timings between each ventricular spike. So what we're seeing here on the circled ones is we've got a spike, but we've got no QRS following that ventricular spike. So these are ventricular spikes, but the QRS has happened just before. So the QRS, the ventricle is refractory. The pacemaker has been unable to capture the ventricle because it's refractory. So it's not sensed the ectopic. That ventricular lead has not sensed the ectopic and delivered a pacing spike. And understandably, the ventricle is not able to be captured because it's refractory. It's just depolarized. So we've got physiologic failure to capture. It doesn't necessarily mean there's a problem with ventricular lead. It might just mean we need to tweak the sensing with the programmer. These complexes are different again, where we've got appropriate sensing. So in these ectopics, they have been sensed by the ventricular lead, and so there's no ventricular spike. And then if you look here, you might be forgiven for thinking, well, hang on, that atrial spike seems to have captured the ventricle. But I don't think that's the case. People may have heard of this thing called pseudo-fusion, where the atrial spike just happens to land just before a QRS. And that atrial spike is nothing to do with that QRS. It just happens to fall there. It's pacing the atrium as a ventricular ectopic lands right at the same time. But it can be confusing when you look at an ECG. You can see this if you had the programmer. You'd be able to see this a bit more closely. So, and then that's a nice example, I think, of a fusion beat. Pacemaker has paced here, a ventricular spike. It's captured the QRS at the same time as an ectopic's landed. So the resulting QRS on the ECG is an amalgam of the patient's paced beat and the ectopic beat. So it looks weird, because you don't see that really anywhere else. So that looks like a fusion beat. And then finally, this ectopic does seem to have been sensed both by the ventricular lead and both by the atrial lead, because we don't see any spikes here. So maybe there's been an ectopic, it's conducted back through the AV node to the atrium and been sensed by the atrial lead, so that doesn't deliver a spike either. So an awful lot going on in an ECG. Bottom line was we just needed to alter the sensitivity on the leads, and it was fine. But at first glance, this patient was sent in, and at one point was heading to the cath lab to have the whole thing, all their leads repositioned and everything. But thankfully, that didn't need to be done. Ventricular safety pacing, I should mention. If you see two spikes that are very, very close together, normally two small squares, 80 milliseconds apart, that is often what's called ventricular safety pacing. And it's like, it's something built into the pacemaker to protect. So it's a means of protecting against the ventricular lead not delivering a pacing spike if it's oversensed something from the atrial lead. So it's something called crosstalk. So when the engineers are devising these algorithms, there's a theoretical risk that when the atrial pacing spike is delivered, it's sensed on the ventricular channel. And if it's sensed on the ventricular channel won't deliver a pacing spike. So there's a concern about loss of output, loss of capture. So ventricular safety pacing is done to try and stop that happening. So if there is a sensed beat on the ventricular channel, which is thought to be secondary to an atrial spike, it'll deliver another activation very quickly, and they're normally about 80 milliseconds apart. So you do see that on a few ECGs. We're not seeing it here. That's the sort of paced normal AV delay that the pacemaker's been set to. Okay, here's the next one. So 12-lead ECG in a slightly different format. So we've got something going on here, something there, something there. So commit that to your memory. So we'll go for the questions. What do you think? 4 choices. Atrial flutter. Something called long RP tachycardia. Supraventricular tachycardia terminated by an ectopic. Sinus tachycardia with a ventricular ectopic. Have a go. Nearly there. I know it's difficult when you can't see the ECG at the same time. My memory is such that if I'm not looking at the ECG immediately, then I've forgotten what it looks like. But well done. Okay, so let's have a look. So SVT terminated by an ectopic, 1 out. No one said atrial flutter. Long RP tachycardia, 1/4 of people said that, and a few said sinus tachycardia with a ventricular ectopic. Let's have a look at this. So that's our ECG. So there's tachycardia going on the left. I know it's not super fast, but it's nevertheless a heart rate of about, I don't know, 110, 120, something like that. And then there's a ventricular ectopic, and then it all changes, doesn't it? So if we look at that tachycardia in a bit more detail, it's not sinus. Look at the P waves. We talked about what they should look like, didn't we, a little bit? They don't really look like sinus P waves, do they? They're the inferior leads. You know, they've got this funny pattern to them. And this is an example of something called long RP tachycardia. So the P to R is shorter than the R to P, okay? So you do see this now and again. It's a type of supraventricular tachycardia. Okay, it's got a 3-way differential diagnosis: atrial tachycardia, or an unusual form of AV node reentry tachycardia, or a sort of very slowly conducting accessory pathway. Now, it used to also go by slowly conducting accessory pathway. Also tends to go by this term, permanent junctional reentrant tachycardia. So I've seen a few. It often is an arrhythmia of childhood, and youngsters present in incessant tachycardia, but I have seen some adults who present with heart failure, and they're in tachycardia incessantly, and this is the mechanism of the tachycardia. They've got a long RP tachycardia secondary to a very slowly conducting accessory pathway. And it can cause, as we said, heart failure, cardiomyopathy. That's another example of a long RP tachycardia due to PJRT. So you can see there the inverted P waves in the inferior leads. It's not sinus, it's a long RP. The RP is longer than the PR. And you know, again, these patients often end up going to the EP lab for an EP study and catheter ablation. They're nice cases to do, usually straightforward. This is the intracardiacs, essentially, of what we saw just now on the 12-lead ECG. But I think it's nice to see. So this is the patient in tachycardia. So this is the surface ECG. It's all going at a sweep speed much quicker than a 25mm sweep speed for a standard ECG. And these are the intracardiacs here. So we've got our patient in tachycardia, and if you like, this is our ventricular ectopic. So on the ECG, one just happens spontaneously. What we've done here in the EP lab is we've introduced a ventricular ectopic, so we've put a catheter into the ventricle, and we've timed it to hopefully land when the AV node is refractory. And if then something changes, you can work out what's going on. And what's happened here is by timing that ventricular ectopic, the tachycardia has stopped, and there's no return back up. There's no A here, so these are atrial signals, and there's no atrial electrograms here. So this ectopic has blocked conduction in this accessory pathway, essentially. So that's one of the means of, if you like, making a diagnosis of the mechanism of tachycardia, because when these patients come to the lab with supraventricular tachycardia, sometimes you've no idea. You know it's one of 2 or 3 things, but you're not 100% certain. And then this, you know, there's a means of working out the diagnosis. So PJRT, these are where they often happen. Here's the coronary sinus, tricuspid valve, mitral valve. They're often located around this area near the ostium of the coronary sinus. And very satisfying cases to do if you can successfully ablate it, patients back to sinus, and if they've had it, we've had a couple of patients who were heading for cardiac transplant at our place, and this diagnosis was that had been missed, diagnosis made, ablation done, ventricular function back to completely normal. So, number 4. You'd be glad to know it's another pacing one. So this was a young lady, 21, 22, who I saw in clinic a few weeks ago. I'll reveal a bit more in a minute, because I didn't have a clue what was going on. So that's her 12-lead ECG. So we'll give you some, you know, there's spikes here, aren't there? Okay. So that was her 12-lead ECG. She's feeling a bit funny, and she come to clinic. Okay, happy with that? Yeah. That was her X-ray, so that's a little clue for you. So the eagle-eyed will see she's got a defibrillator in. Okay, that's a coil on the ventricular lead. So it's a dual chamber ICD. Okay, fine. So I'm going to muddy the waters a bit and say that her ICD had been programmed to what's called AAI. Now I'm guessing most people are saying, what is he talking about? We'll come to that in a moment, but anyway, so AAI means that that device is not looking at what's going on in the ventricle, it's only looking at what's going on in the atrium. Okay, fine. So, here we go. What can be deduced from the ECG? I think I need the physiologist and the programmer back, please, which is what I said, actually. Here's those fusions again, pseudo-fusion, pseudo-fusion, or that's what I would expect the ECG to look like. So, have we got the pole? Yeah, are we nearly there? Okay, fine. So, see what we said? Yeah. Yeah. There was myself and 2 registrars, and we were all looking at it. We were all saying different things. Someone said, "Where's the physiologist? Let's try and get to the bottom of it." Okay, let's have a look. So, So a little bit on pacemaker codes, just, you know, it's the convention of 3 letters, or we could, you know, 4 and 5 have come in sometimes, but the first letter on the code tells you what chamber's being paced, the second letter tells you what chamber's being sensed, third letter says what action is being taken by the pacemaker. So VVI pacing, so we're talking about a patient who's got one lead in their ventricle, okay? So their pacemaker only looks at what's going on in the ventricle, and it will pace the ventricle, and if it senses an ectopic appropriately, it won't deliver a pacing spike. Yep, fine. AAI, which is what this young girl was, it's the same, but it's in the atrium, not the ventricle. So it's not looking at what's going on in the ventricle. It's pacing the atrium, Oh, hang on, it sensed an atrial ectopic here, so it doesn't pace, and then it goes back to pacing the atrium. And that's how she'd been programmed, AAI. So she had a lead in the ventricle, but if you like, it had sort of been turned off. The ICD was looking at the atrium only. So ICD programmed at 60, we've seen that ECG already, we're still trying to work out what's going on. But hang on, what's going on now? Physiologist has come along and turned the base rate up from 60 to 90 beats a minute. Okay, so we're now pacing at 90 rather than 60. Something's changed, hasn't it? It's not the same ECG anymore. Everyone agree? Yeah, good. Just as a quick aside, have a look at that, please. Get that into your mind's eye. We're going off on a little slight tangent. Why has this patient got an ICD in? So I know that wasn't the original question, which is what on earth's going on with this ECG, but given that we've had a different look at the ECG now, at 90 beats a minute, why have they got an ICD in? And hopefully you could pick up why. When the ventricle wasn't being paced, it wasn't on that last ECG, it was a narrow QRS. Hopefully you could pick up why. How are we doing? Nearly there? I once did an ECG course as a registrar with Hein Wellens and the late, great Mark Josephson, and it was a bit like this, but what they did was they came into the audience and pulled somebody out to the front to go through the ECG and basically completely humiliate you.
That's what we're going to do in 15
Is that right? Yeah, I thought you might say that. And the more you tried to avert your gaze while they were looking through the audience, the more likely you were to get picked. So it's so difficult to hold the stare when you're terrified about getting picked out.
And that's why they became interventionists.
Yeah, exactly. Exactly. So, what did we think here? Long QT, one out. Good. That's the correct answer. I thought I threw in short QT for the sake of it, but it wasn't that, was it? Rugarda, I didn't think it looked like that. We'll go back to it now. Some people said arrhythmogenic cardiomyopathy. So that was the ECG, paced at 90. Remember, we still haven't explained our one paced at 60, while that was so different. So this was also her ECG when she presented, before she had her ICD in, and she had been treated for epilepsy for a couple of years because of these weird collapses. So she didn't have epilepsy, she has long QT syndrome, she was having bouts of torsade de pointe, polymorphic ventricular arrhythmia, which was seen on the monitor actually. She was admitted to the local hospital. They were waiting for the neurologist to come and see her to try and sort out her anticonvulsants, and then they saw all this going on the monitor. You probably had similar stories. So, and what was interesting here, I thought, so it's a grossly prolonged QT, yeah? Grossly prolonged QT. Look at, never trust these blooming reports, yeah? Borderline normal. I'm sure, you know, everyone doesn't trust them. You know, 496, so that's not right. It measures out as over 600 milliseconds. She's been genotyped, she's got long QT2. You know, there's different subtypes of long QT. So she went on to have ICD. Back to the original offending ECG. What's going on here? I think I then went to another question. So the physiologist has come, got bored, gone off. So we're still none the wiser what's going on. Plead with the physiologist to come back with the programmer. Please help us. Is there a lead issue? Is there a ventricular lead issue? Is that what's going on? It captures the ventricle at 60. It's not capturing the ventricle at 90, but it's been programmed AAI. So what's going on here? Is there a lead issue? Is there a programming issue? Or can we just not work this out? Let's get the physiologist back. Are we nearly there? Nearly. Okay. Let's have a look. Programming issue. Yeah, that won out, didn't it? And I think that's sort of right. Other people said other things. We saw the X-ray, didn't we? So we know that the ventricular lead is towards the apex, yeah? And yet those QRSs are upright in the inferior leads. So it can't be captured from that lead. And anyway, it's programmed AAI, so that ICD lead shouldn't be pacing. This is basically what was going on. So AAI at 60, AAI at 90. At 60 beats a minute, when it's pacing in the atrium from the atrial lead, it's also capturing the ventricle, I'm guessing, around the outflow tract. The right ventricular outflow tract, sort of wraps over the top near the right atrial appendage. They're close. We know they're close. You often see an R wave in the atrial lead. It's sensing the atrial activity, and here it's sensing the ventricular activity, because it's close. And here, and I've not seen this before, it is reported in the literature, I had a look, there's a couple of cases, but here we've got capture at 60 beats a minute, the atrial lead's capturing the ventricle, and yet at 90 beats a minute, it's not. So I presume that whether that's a mechanical thing, if you're pacing the heart a bit quicker, it's sort of pushing off the outflow tract away from the right atrial appendage. Dr. Asvathan will be able to speak far better than I on this, but whether that's the issue, that it's purely a sort of local mechanical capture. But anyway, that's what was going on. But it does matter. This girl had been, in the UK, ICD checks are only done annually. It's probably different in the States. So patients go quite a long time between one check and another. And I think she'd been walking around having this paced ventricular rhythm for a year, at least, which probably doesn't do you a lot of good. Who knows if it might lead to long-term ventricular issues. So they are important things to sort out. So, got a few more minutes, I think. Right. What about this one? So, ECG. So we've had a go at interventional cardiologists, haven't we? We're now going to have a go at cardiothoracic surgeons. They're always good to have a go at. Have we got any in the room? No. So, okay. So that's the ECG. Okay. So what's going on here? Is this atrial fibrillation, atrial flutter, atrial tachycardia, sinus rhythm? I'm being a bit mean because if I give you a story, it'll help, but we'll just start off on the ECG. But I think that's a good point, isn't it? When you're looking at ECGs, it's always worth taking history as well, obviously. The other thing I learned was if someone hands you an ECG and you look at it and it looks totally bizarre, utterly bizarre, you can't work out what on earth's going on, always ask for it to be repeated. Because when they go off to repeat it, they might have wired it up incorrectly, but also when they disappear around the corner, you can quickly go onto Google and try and have a look what on earth this thing is that someone's been handed to you. Okay, have we done all the polling? Yeah, fine. Atrial tachycardia, good. Good, not sinus rhythm, good. Doesn't look like sinus P waves, does it? Flutter, okay. I mean, when you're talking about flutter, I know flutter, but it's nice to get into the habit of thinking about typical flutter, atypical flutter. But we can come to that. So that's the ECG that we just looked at. So this is at rest, and again, you would question, why would someone be in a sinus tachy at 118 when they're sitting there not doing anything and they haven't been exercising? It'd be a bit odd. They don't look like sinus pivos anyway, do they? If we look closely, they just don't. This is someone who had surgery. They'd had bypass surgery and a Mayo procedure, which is a procedure to try and treat and cure atrial fibrillation at the time of bypass surgery. They'd not been well since surgery. In fact, it felt a lot worse. And they went to see the cardiothoracic surgeon for follow-up, who said, "You're doing fine, your ECG's normal, we're discharging you." And then months later, he did eventually come back to our clinic. And so we put catheters into the heart, and this was to show, so this wasn't sinus rhythm, which is what the surgeons had said. We've got two atrial electrograms to every one QRS. This patient was in an atrial flutter. Now, it wasn't what one would call typical atrial flutter. Looks slightly different on an ECG, but this was an atrial flutter, and it was really on the back of, because they'd done this, and surgical Mayo procedure, you could have a whole day of talking about surgical Mayo and who should do it and who shouldn't do it, and does it work or does it not work, but it's essentially you're making cuts or lines in the atria, series of lesions or cuts. Eventually, it's sort of like trying to divide the atria into smaller pieces to try and stop atrial fibrillation happening. And in some centres, they'll do a lot of this. In other cardiothoracic centres, they may not do much of it. But if it's not done properly, it causes lots of problems. Because it causes incessant arrhythmia, because if these lines are not complete from one end to the other, and there's little gaps in them, it allows flutter circuits through. And then a patient could go from having the odd bout of AF before their surgery to being in an incessant atrial flutter where they feel terrible. And that's what happened here. And this is just, we put catheters in the heart. We created scar mapping. You heard a little bit earlier about scars. And the red is scar. And essentially, this was a line that the surgeon had done from the tricuspid valve back to probably to the a line they'd created, intercaval line, and this line is not complete. There's a little gap there, and there's probably some little gaps there, and that's where this circuit was finding its way through. So the ablation in this particular instance was quite straightforward. If you target those areas where there's gaps, you want to make a bit of scar essentially to complete the line of block, and then you'll terminate the arrhythmia. So flutter. Yes, it's like, what does the ECG show? 1 point if you say atrial flutter, 2 points if you can say either it's typical or atypical flutter. 80% or 90% of atrial flutters are typical, and the rest fall into an atypical, and that can be due to all sorts of things. Patient might have had surgery before, as we've just been talking about. They may have congenital heart disease, so on and so forth. I'm going to skip through this, but that's an ECG of typical atrial flutter, yeah? So it's not like the ECG we just looked at, but it's typical, isn't it? The sawtooth pattern here in the inferior lead. A nice thing is to look at lead 1, which is normally flat. You don't see flutter waves in lead 1 because the circuit's perpendicular to lead 1. And then in lead V1, it's normally a positive flutter wave. So there's a characteristic pattern to be able to say, and it makes a difference, because if you see an ECG of typical flutter, it's normally quite straightforward to fix by catheter ablation. I've got time for one more, hopefully. I'm going to skip over my beautiful textbook case of atrial flutter. Happens about once every 10 years. So anyway, there we go. So we're going to go to one more question. Right, here we go, last question. Okay, hope you can see it. It's a bit grainy, it's real life. So have a look at that monstrosity. This was when I was on call a few weeks ago, actually. This patient came through to us. We don't have an A&E either, so that's quite helpful in a way, in lots of ways. But the patients end up being referred to us. Okay, so what can be deduced from the ECG? I am uncertain of the rhythm and will consider giving adenosine. Pre-excited AF, SVT with bundle branch block, VT. Okay, how are we doing? I've only got a few more minutes, so... Okay, happy? So VT, 1 out, good, very good. A few people went for other things, pre-excited AF, SVT. So a few went for that one at the top. Okay, I won't ask you to put your hand up. But, now, I'm glad some people did go for that, because that's what happened, actually. So, and she had cardiac arrest. Okay. So we have a bit of a vogue, certainly in the east of England where I work, where in the local A&Es, adenosine is given quite frequently for tachycardias of any description. Now, in my view, I think that's a bad move. Adenosine is a treatment to terminate a narrow, complex tachycardia. I don't think it's a means of trying to work out a mechanism of tachycardia, which is, I think, why it was given here. You know, the premise is we'll give adenosine. Oh, if it doesn't work, it must be a VT. I don't think that's a good thing to do for several reasons, but one of them being, if you're into the habit of giving adenosine to everyone who walks through the door with a tachycardia, have a look at that. I think we've got a question. Have a look at that. I think we've seen an ECG already like that earlier on. So same, probably giving a clue as to what people are not going to say now. But there's the choices like we had before. Okay, same choices as before. Horrible looking ECG, isn't it? Okay, we'll go for it. Good. Good, so the 13% from the previous have now thought better of it. Excellent. Everyone, well, lots of people could spot pre-excited atrial fibrillation, which is a life-threatening arrhythmia. If you give adenosine to somebody with that, you could cause a big problem. There's a little bit in the literature on it, but this is someone with pre-excited AF, or it may have been an animal model, I'm not sure, but adenosine was given and ventricular fibrillation ensues. And my point is, if you're in the habit of giving adenosine to broad complex arrhythmias, I think you're at risk of causing a lot of trouble. I mean, this particular patient, she was a cardiac patient, so that's a clue. The broad complex tachycardia in someone with a cardiac history, it's likely to be VT, isn't it? It's likely to be VT anyway. You know, most broad complex tachycardias are VT until proven otherwise. And I don't think you need to be, so the thought process from some might be, oh, could this be SVT with bundle branch block, yeah? I'm guessing, and that's why some people are thinking, oh, maybe we'll try adenosine. But for it to be SVT with bundle branch block, you want to see a normal, like a typical bundle branch block pattern, don't you? Like, to be confident. And this isn't, is it? That's what typical bundle branch block, right bundle branch block, looks like in V1. And that's what it looks like in V6. It doesn't look anything like that, does it? Look at that, it's just like a big, broad, positive thing where the first R wave is the dominant one. And look at it in V6. So that doesn't look like typical right bundle branch block. Someone's got a history of cardiac problems. This is overwhelmingly likely to be a ventricular tachycardia, not SVT with bundle branch block. And I think with her, she had a systolic pressure of about 90. She's just sort of hanging on. Someone gives adenosine, causes vasodilatation, and she crashes. So please bear that in mind. We're finished now with just a couple of slides. So this was a patient who presented to the local GP surgery. He'd been completely fit and well, 21 years of age, and said he wasn't feeling very well. Could he see one of the GPs? And the receptionist said, absolutely not. Come back next Tuesday for an appointment. And then he had a cardiac arrest in the surgery. So this was pre-excited AF. So this is his first presentation of WPW, which is rare, but we see it occasionally. And then the ECG has subtly changed here, where he's gone into ventricular fibrillation. So the ventricle is going crazy here. He's in atrial fibrillation. The ventricle's being driven extremely quickly by conduction down his accessory pathway. It can't cope, and it degenerates into ventricular fibrillation. Previously, so he hadn't had an ECG in the past. When he was resuscitated, we could see, so can everyone see the delta waves, so WPW, but this was his first presentation. It is rare. We did an ablation, little point then at the end. So the delta wave has gone. So his WPW syndrome is gone. And a handy tip as well, can you see these little septal Q waves here? So that's normal septal depolarization. You see them in these leads, sometimes see them in lead 1 in AVL. So if you're handed an ECG and, I think this patient's got WPW, if you can see these little septal Q waves, it's probably not, because that tells you the septum is being depolarized normally, rather than this patient has an accessory pathway and they've got abnormal septal depolarization. So I shall call it a day there. Thank you very much.